So this patient, let me just double check the exact history. The history was patient has rectal cancer and fever, and the concern was, something happening, so evaluate for biliary obstruction. So this was, let me just take out the measurements so you can see. Patient's a little motiony. You can see that there is buildup, right? And kind of like we lose the duct a little bit at the confluence. And then if you come here, you can see that it has like this, something is happening at the confluence. There is buildup. The duct is normal caliber distal, but there's something here. And I don't know, here you can see these stupid things that go away. There. You can see that there's kind of circumferential enhancement at the common hepatic duct. You can see upstream biliary tree dilatation. And then when we looked at, there's T2, that fat side, you can see similar appearance here, just kind of circumferential mass-like thickening. And patient had, you can see not biopsy, ablations for liver mets. Arterial phase is not perfect, but there's nothing like terribly abnormal in terms of enhancement in the liver. Of course, cholangitis may just kind of be very non-specific. So, at this point we said, okay, there's buildup, there's some sort of mass-like circumferential enhancement here at the confluence with upstream biliary tree dilatation. So, we gave, and remember, patient has metastatic rectal cancer. And anyway, so we provided differential diagnosis. We said, could be some sort of weird metastasis, very unusual appearance for metastasis, but the patient has metastatic rectal cancer, so I have to kind of start thinking about that. Cholangiocarcinoma, of course, again, for a patient to develop two primaries, not impossible, but slightly unusual, slightly less usual. And another thing we threw in there, some sort of focal, like a weird mass-like inflammatory process or infectious process, something having to do, something benign, inflammatory, infectious, that makes it look like cancer. So we said, we can't really tell any of these apart just based on imaging. So we said, please get a biopsy, which they did. And it came back as, negative for malignancy, chronic and acute inflammatory changes. And then they saw purulent bile when they canalized. And so this is just kind of very odd looking cholangitis.
Victoria, can you scroll through the liver on this again? I was just like, initially was wondering if there was beating of the ducts, but I guess you can, now I'm seeing you can follow them all centrally. Okay. Because sometimes I feel like subtle PSC, I see it best on the venous where like I can see the ducts coming and going, but here I don't definitely see that. So,
I mean, here's let me see if I can get the T2 here.
But that's what I'm saying. I feel like I see the beating better on the venous and when it is, but yeah, this doesn't really look like it's beaten. So, okay. Wow. So the other, it was question I was going to ask, did you guys look at like what therapy they're on? Is there any kind of like cholangitis associated with those therapies?
Believe I have to look it up, but I think that, let me see. Let me just grab.
Wait, Roopa, can you repeat what you just said? You said you had a similar case, and
yes,
it was
we
what?
had a similar case of fungal cholangitis, mimicking cholangio in a non-immunosuppressed patient. So I wondered in Victoria's patient with history of malignancy and being on all sorts of chemo and medications, that's a relatively immunosuppressed state too. So I was curious what the pathology term organism was. So and she said it was infection.
It is infection, some sort of infectious purulent cholangitis. I'm looking, patient had chemo RT for primary and then liver directed, it looked like patient had several ablations. So based on what I see, patient was not on chemo during this, like at the time of this, what happened.
My surgeons have told me that, like hilar cholangio, often they don't have a path diagnosis before they go to surgery because the brushings are really poor. It's hard to get the diagnosis. And of all of those, about 10% end up being not malignant. So they end up being some kind of pseudotumor, IgG4, some kind of inflammatory process. So yeah, it's a tricky one.
Yeah.
It almost looked like the duct penetration you talk about, right, Aarti?
Yeah. I was thinking that, like, if it was truly a cholangio, would it let the duct go through it? But I mean, in that case, you have to say like this is concerning for like an infiltrative cholangio until proven otherwise, I guess. Or I guess a superficial spreading cholangio.
Right. Well, I think if I remember correctly, and let me just double check that patient had a CT. So I didn't have a MAR, but recently MAR, but patient had a CT about, let's see, month and a half to 2 months before the MAR, and it was completely normal. There was no bill deal, there was nothing there. So that was kind of another reason why we thought maybe cholangio would be too unusual to develop so quickly. But again, like the differential is provided as mets, cholangio, or some sort of atypical infectious process, which this ended up being.
Nice.
Best case scenario. Okay. Okay. So this is a 60-something-year-old patient coming in with right upper quadrant pain. 3 to 4 months worth of pain.
Oi.
My first thought was XGC, Xanthogranulomatous cholecystitis, because of the like cystic spaces in the wall.
Right.
But I would want to get an MR in this and see if make sure all of that stuff inside is not enhancing and it's just like sludge and pus.
So that's kind of how it got read outside too. And it almost reminded me of like the bear paw and XGP like appearance, right? Except it's gallbladder also. And yes, predisposition with stones and chronic coli. And it was the same concern. They were not sure if there was any solid enhancing component, and rule out malignancy was the question. So they actually recommended that there be a biopsy of this, which is what they did. You can see the biopsy needle within the gallbladder. Thankfully, it all came back as just inflammation, but then post-biopsy patient returns for new onset abdominal pain, which they said felt different from this chronic pain that they had had. So just scrolling through the area of interest. So that's arterial. This is portal venous.
Is there like a blush? I just saw.
There you go, yeah. So this hyperdensity here is mu. It's in the non-dependent portion also, which is another clue. And the air is right along where the biopsy tract was. So this was actually a post-biopsy induced pseudoaneurysm. And then IR had to go and coil the cystic artery. So easy to overlook because it looks dense, similar to these gallstones, but the position is different. And I guess having the old scan was very helpful because this was not there before. And then there was a biopsy in the interim. So nice example of XGC with post-biopsy complication treated by IR embolization.
So I haven't seen that many gallbladders biopsied. One, because people are always scared about seeding, although supposedly with, coaxial technique, that's much less likely in most tumors, although people are still kind of concerned about gallbladder because it's so aggressive and infiltrative. So I guess just in retrospect, do you think that MR would have been the better next appropriate step?
I don't know, Aarti, if it was sludge and it would have restricted, would we still be 100% sure using post contrast? I guess where there would be no nodular mass like enhancement. Maybe so.
I think I would feel confident if there was no
Yeah.
enhancement, but there was restriction. I wouldn't be concerned because you can get
Sludge can, right?
Yeah. In sludge or abscess, right? It still doesn't mean it's not. I've seen so many actually gallbladder abscesses that restrict and people are concerned, and it's like, no, abscess can restrict, and then even sludge can restrict, and like restriction is so non-specific. So
Right. Yeah, more imaging maybe would have saved a complication, right?
yeah.
Yeah.
Okay. Yeah. Okay, so we have a pregnant patient. And I'll show you the SAG in a minute. This is the axial.
Placenta is low.
Yeah.
Yes, the placenta is low. Let me show you the SAG because that'll be the clincher for that one. SAG. Okay, here. Okay, so we've got our low placenta. So placenta previa. And actually, this is the cervix here. And there's the placenta.
Looks like more placental tissue going out at the end.
Yeah. So exactly. So here there's this weird thing that looks almost like separate, but if you go back to the T2 that I was initially showing, so here we've got our placenta, it's posterior, there's placenta previa, it's low, and then you've got these vessels, and then this placenta that's bulging severely posteriorly. We thought it was like touching the rectum here, and touching the bladder. So, and then some of the things, so we were worried about abnormal placentation. Some of the things you look for the placenta percreta, increta, percreta spectrum is two dark bands, which we thought maybe this was one of them. Lots of, bigger vessels, especially at the myometrial serosal junction, which I don't know, this is like basically, we thought the placenta was like just frankly bulging out here. Really, and like basically couldn't see the myometrium. The one caveat in this case is the patient was 38 weeks pregnant. And you're supposed to really be looking for placental abnormalities between 27 and 30 weeks because that's when, if it's too early, the placenta might not have like settled into place. And if it's too late, the myometrium can get really thin and you can't really say like, oh, is the myometrium gone, or if it's not. But this case, we're really suspicious. They ended up getting a C-section and hysterectomy. This patient had previously had an abdominoplasty, so they had a lot of adhesions, but they saw the placenta completely bulging, but not invading any other structures. And on path, this was a placenta increta. So it was invading, it was like completely sort of like thinning and bulging the myometrium, but not extending beyond the myometrium.
I think it's unusual, right, to see posterior.
Yeah. So here it was, very unusual. And usually the risk factors are multiple pregnancies and multiple prior C-sections. And often the placental abnormal placentation is like an anterior placenta along that sort of like C-section area. So this is pretty unusual to have it kind of go like this, but this was a case.
So any previous like dehiscence or surgery or anything, it's kind of going in the rectovaginal septum almost.
There was no previous surgery, but let me just check to see. I think they had prior, they definitely had the prior abdominoplasty.
Which is why you would think between the C-sections and anterior abdominal wall plasty, the increta would be much more anterior.
Yep. Let's
diffusion weighted imaging on that?
Let me see.
Because there was a case where I overcalled what I thought was placental tissue extending. It was like pericervical or beyond the uterus, but then the gynecologist, high risk gynecologist, OB gynecologist showed me their ultrasound, and I was like correlating with the ultrasound to my MRI, and it ended up being, I think, slow flow veins probably that was sort of mimicking extrauterine extension of placental tissue, and it was easier to judge honestly on the diffusion weighted
Hmm.
after I looked
I-
at the case some more.
Okay, so now I've got my DWI. My placenta is restricting. And actually it's interesting because the part where it's bulging,
Yeah, you see that? It's not restricting, right? Or not as much.
well, yeah, actually, to be honest, if I line them if I line them up side by side, it's not really restricting. Like it's actually here where that tissue is.
The
Yeah.
the site that you were looking at saying, what about this? What about this? Right? And
Right.
when you look
Yeah.
at restricted diffusion, it looks like it stops
Right
before
there.
it's there, right?
Right. But so in this case, it didn't help though, because on in the OR and on pathology, this was actually completely like very bulging placental tissue here.
Okay.
This is the cervix when I correlate it to the T2 pushed off to the side. So I don't know if the diffusion helps, but in this case, it's a very interesting point. But this was, yeah, it was this, like they said, this was all bulging placenta here. So, and I believe them, it looks like it, right? Maybe it was dead, or maybe it just like is different kind of flow to it.
I guess.
Not as vascular.
It makes me want to pull up a case.
Go for it.
No, I gotta find it.
Okay. Okay, I'm gonna stop.
Okay, so this was a older patient who came to us for evaluation of a cystic lesion in the pancreas. So you can see that, the pancreatic duct was a little dilated, and we saw this kind of lesion here. And then this is, and about 4 months ago, hold on a second, let me just, it's about 4 months ago, you can see that the pancreas was pretty normal. So any thoughts?
Well, the 4-month thing is a little weird because first I was thinking like, is it an exophytic IPMN with like the main duct involvement? But 4 months would be super, super rapid for an IPMN.
Right, so,
But the duct does look really bulgy like an IPMN.
Yeah.
right. Well, the patient actually, we found out, had pancreatitis in the interim.
So then it could just be like a blown out duct pseudocyst. It does look if you trace that duct, does it go to like a stricture or stone or no, in the head? Like yeah, it almost looks like maybe a stricture or fibrosis. Like there's an abrupt truncation of that duct. I'd want more multiphasic imaging to make sure there's no mass there.
Okay, well, I was actually wanted to talk about this, right? So you said pseudocyst, right? Yes?
Yes, I
Yes.
did. I said or blown out duct, disrupted duct.
So let's focus on this cystic lesion. This is a MR that was done, very close, like within a few weeks to a few days of the CT. Would you still call it a pseudocyst?
The duct looks like it ends in the thing, right? It's abruptly ending.
Okay, well, forget about the duct. I want to talk about this.
Yeah, I mean, there's a lot of debris in it. I thought I saw
Yeah,
some
on
debris.
subtractions, it's not enhancing, right? There's just debris.
Unfortunately, we don't have the subtractions of the outside study, but let's assume it doesn't enhance.
Maybe like, in the spectrum of walled off necrosis, like
Yeah.
peripancreatic walled off necrosis.
Right, so this is really why I brought it up, because again, this is like within like two weeks of each other, these, right? So if we saw this, it looks pretty relatively simple, not debris, right? So we would be inclined to call it a pseudocyst, but the concomitant MRI, you can see how much like crud is inside. So this is walled off necrosis. So this was all post-pancreatitis findings. So just to show you, these two MRs are separated by 1 month. So this is the MR, and then 1 month later, this is what the patient looked like. So at some point between these two, like within the month between these two studies, patient had pancreatitis. You can see this was a walled off necrosis, and then it just kept following the patient. So, when we go back and look at the Atlantic classification, they caution that, a lot of what we call pseudocysts actually end up being walled off necrosis, and CT is very insensitive for all the debris and gunk that's inside of them. So, anyway, so I thought it was like a nice example of how MR shows all the debris that CT kind of misses.
And the main difference is that pseudocysts we often don't treat. They can resolve on their own, or they're as long as they're asymptomatic, we leave them alone. Whereas walled off necrosis suggests that there was more necrotizing pancreatitis, more severe disease, often have to be drained either by us, by GI, or sometimes by necrosectomy.
Right. So if there's no symptoms, both can be left alone. Chances are walled off necrosis will require treatment much more often than pseudocysts. My understanding is the most important kind of distinction is that, it looks like you just pop in, you would just pop in a drain, it would just suck everything out. But in reality, this is not liquid. This is all like necrotic gunk. So often putting even the largest of our drains is not enough to drain this out. So I think that's even more important, because let's say a patient is symptomatic, right? A pseudocyst, you can just put, 10, 12-inch drain and should come out. But with a lot of times with these walled off necrosis, our drains are just not going to cut it, and they do have to do either large bore surgical drains, or now they just put the Axios stent, and all this gunk is going to come out into the stomach.
Yeah, that's one thing that my GI guys always want to know, is there a well-defined wall, so that they feel like they can do the percutaneous gastrocystostomy. And then 2, are there any varices in between that wall and the stomach? Because often the splenic vein gets out, there's varices, and that will affect their ability to get into it. So,
Victoria, I have a question.
Yeah.
In your case, you had previous imaging and a definitive normal study and a very abnormal study in a good timeline to say it's walled off necrosis fitting into Atlanta criteria. But many times, if we don't have imaging and we're kind of in that 5 to 6 week window when one is ending and the other is beginning, what imaging features do you use to lean this way or that?
Yeah. A well-defined wall. I think, the 8 weeks separation is actually, you see, I think I have dyslexia for numbers, for even numbers. I can't remember if it's 6 or 8.
it's 4 weeks to go. It's 4 weeks to go from like an acute necrotic collection to
Even
Well,
I literally cannot distinct, my mind cannot remember. But anyway, this 4 weeks is arbitrary, right? And
I was just gonna say, our gastroenterologists actually don't even use these terms. They literally don't. They're just like, okay, how is the patient doing? And usually these necrotizing pancreatitis patients are doing much worse. They have much higher morbidity, mortality. They're the ones that are in the hospital that haven't just recovered from supportive care, and so they're going down this whole other pathway. And they don't even use they're if debating between a pseudocyst versus walled off necrosis. They actually call them all pseudocysts, and we're the ones that kind of are using this terminology, but they're treating them clinically like that,
Right.
And often they have a disrupted duct that's still feeding it, or this walled off necrosis is much more susceptible to infection. And the patients are still really sick, and then they still have to drain them,
Right, but back to Rupa's question, if you don't know the timing, I think the whether or not you have a nice well-defined wall is what distinguishes between acute necrotizing collection and walled off necrosis, and similarly between just peripancreatic fluid and pseudocysts, that you want to see it well defined. And if you have a patient with necrotizing pancreatitis that had serial imaging, you'll actually see it, right? And it starts out very ill-defined, just necrotic everywhere, and then over time it will begin to organize, and at some point you'll start seeing that nice wall, and it typically happens around 4 weeks. But if it happens earlier or later, I think that's where the kind of, if you don't know the timeline, where you would you would kind of start calling it that.
Victoria, I have one more point about your case. I feel like it's still like an unusual case in that it's unusual for a patient to just get pancreatitis and then suddenly have all this duct dilation without having like, the fibrosis is usually in like repeated pancreatitis or chronic. So I would still follow up. This is the type of patient that I would want to get a follow-up and make sure there's no underlying mass that actually caused the pancreatitis and is now causing that ductal dilation.
Right. I'm just trying to see what, no, they just keep saying history of pancreatitis. No, that's a great point.
So we always say like any interrupted duct, you should try to make sure there's no mass there because it could be occult.
Right, so the way we read it, unchanged irregularity, dilatation of pancreatic duct, upstream to pancreatic head, probably due to a stricture, although small obstructing mass remains a possibility. And recommend endoscopic ultrasound, because right, if it's a cancer, you don't want to just sit on it. But I don't believe that that's what they did.
Yeah, and that's the tricky part about pancreatitis is like you get consumed by all the inflammatory stuff and like forget like, oh wait, we should definitely be excluding a mass that could have been causing it.
Right.
Okay, it's an interesting scout. Do we see anything?
I see the tip of a belt buckle,
Okay, good.
but I don't think they ingested it.
No, move a little higher up.
Oh, I see a zipper too.
Okay, keep going up.
Keep going up from the zipper?
Yeah, come into the pelvis.
Oh, I meant the zipper in the chest. Okay.
Oh, the zipper in the chest, yes.
Okay. Maybe density over the left iliac wing.
Okay, that was just dense contrast and fecal material. What do we think of this area? It's a little hard to prospectively say anything, but it looks so cool on the CT when I show you in a second.
Looks like kind of modeled like arcs and rings.
Almost like either chondroid or osteoid type matrix. Victoria, what did you say?
I said I.
You know that word.
Yeah.
Wait, is this a male or female?
It is
Male.
a male.
Male, right? Is this like a prostatic stump tumor? Or
No, it's actually in the rectum, Aarti. That was my first thought too. Is it some kind
is it a hemangioma? Or a mucinous adenocarcinoma?
Okay, all good thoughts.
No. Okay, so that definitely, I retract my hemangioma because it doesn't look like phleboliths.
Okay. So here's
Like, oh, wow. It's like an intussuscepting huge polypoid mass.
Yes.
Tubulovillous adenoma with mucinous differentiation.
It actually on biopsy turned out to be adenocarcinoma with heterotopic ossification. I know, which is rare, but the importance we realized is apparently there are these chemicals called bone morphogenic proteins and fibroblast growth factors, which promote formation of mature, like ossified matrix within these tumors. And if you have a T3 but with these BMP and FGF2 immunohistochemistry positivity, that actually carries a poorer prognosis than a routine T3 adeno would have otherwise. So it was very interesting. The pathologist said, if you only gave me this piece of tissue, it looks like osteosarcoma under the microscope. It's just mature osteoid bone.
Wow.
I just thought it was very cool on the scout, and then there's a little interception.
Roopa, I'm so sorry. I had to take a phone call. What was the final path?
It's adenocarcinoma with heterotopic ossification.
Wow.
Yeah.
Which she said has a worse prognosis and under the microscope just looked like an osteosarcoma.
Yeah.
I have a question. So it was not arising in a TVA. This whole thing was just like completely.
We don't know. This is just.
This
is the first imaging we have, and on the path they didn't say there were any features of TVA. They said outright malignant features, atypia consistent with adenocarcinoma.
Nice. In general, I would say when I see like a big stalk-like mass like that in the colon, I think about a TVA that then had adenocarcinoma.
Malignant. Yeah, mucinous was the other one we thought of also, I think, because those can calcify. But the architecture of this was more bone-like under the microscope, so they called it heterotopic ossification.
Never heard of that, but I've
I
seen
know.
that in renal cell.
Yes,
Yeah.
I have a case. Let me pull that up. I remembered to show this case too. Let me pull that up while you talk.
Okay, I'm going to show a case. This is just a cute, quick one. Okay. So patient, let me just make sure. Okay. Patient presented with GI bleeding.
See some hyperdensities in the proximal jejunum.
Okay, that was just some food.
Okay. Oh, diverticulitis or some inflammation in the anterior abdominal. Right.
You mean in the colon?
Yeah. Is that
Okay,
colon?
yes. Colon, focus on the transverse colon here.
It's a bit of an intussusception with a mass.
Yeah, exactly. So we've got our part of our colon and mesentery being pulled in, so intussusception here, and then we've got this like sort of apple core-ish mass with more of an intraluminal component. And then I don't know what do you guys think about, do you think there's more mass here? Like a second mass, or it seems like there's like intervening normal colon here in between. But this part also looked a little abnormal, although there is a bubble there, so I don't know what that means. Anyway, I would have said that this was a colon cancer, right? Like looks kind of apple core-ish, causing an intussusception. I will tell you this was a rare diagnosis. It was not a colon cancer. Any other thoughts? Aside from this was not osseous metaplasia.
Some sort of
Any pseudotumor from inflammatory bowel disease?
Good thought. We can get pseudopolyps in IBD. I would say, and IBD also has a higher risk of malignancy though. So we would definitely have to go chase it down if they had IBD, but I think this is too much soft tissue. So this was a malignancy. It just wasn't colon cancer. So I'll just cut to the chase. This was a leiomyosarcoma of the colon. And what I thought was interesting, so I'm going to show you a follow-up, but just a couple of points about colonic leiomyosarcoma. These are very rare. They're less than 5% of GI malignancies. In the past, when we saw a sarcoma of the colon, like there was some, there wasn't as much like pathologic differentiation, but now most of them are going to be just tumors. Leiomyosarcomas are really rare. But unlike GIST are more common in the stomach, and leiomyosarcomas are more common in the small bowel and colon. They have a very poor prognosis. They tend to be large. They can be heterogeneous. They can calcify, kind of like other leiomyosarcomas of the retroperitoneum. And I'm just going to stop sharing for a second. I just want to pull up the follow-up and show you the follow-up. So this is now a year and a half later. So they resected that tumor. Oops. I don't know what happened. I'm sorry. Okay, well, it went into some weird mode. But anyway, you can see that there are a lot of Mets. And these Mets don't look like typical colon cancer Mets. They're very cystic, necrotic, different stages. So more solid, more cystic and necrotic. None of these were there before. So very aggressive within a year and a half, had like big liver Mets. And then they'd had their colon, transverse colon resected. So we have a side-to-side anastomosis here, but already has liver Mets. So colonic leiomyosarcoma. But I think retrospective diagnosis.
This is a gravid uterus with a patient that was supposed to have a planned gravid hysterectomy for fetal anomaly, and she was advanced maternal age anyway. There was an ultrasound that was done, which I don't have images from, that showed suspicion for spectrum. And so I was doing this MRI to judge that. It's a little bit earlier in, like you were saying, the best window for doing an assessment of placenta is, I can't remember what the range is, but this is sort of
I
early.
think the late 20s, like,
Yeah.
yeah, 27 to 30 weeks.
Yeah, so this is a little bit earlier than that. But I did call some lobulation to the placenta and maybe a couple of bands in here, and then the basement or placental myovitreal interface is very kind of puckered and irregular. Usually it's more uniform. And then if you go to the they actually did contrast enhanced imaging. Well, maybe you can see it on this T2. There's kind of a lot of vasculature, more vasculature than I'm used to seeing, and I didn't know how much of that was due to just the pregnancy itself, or maybe she had a little bit of pelvic congestion because a lot of this looks venous, although there's some flow voids in some of these as well. And then when you get to the anterior side where they were looking at things and saying, sorry, there's some motion on some of these images, but you see a lot of flow voids there and the quite irregular interface here. Now, I didn't call anything that I thought was placental tissue traveling beyond the outside of this, but I thought that the degree of vasculature was excessive compared to what I'm used to seeing. But again, this is a little bit earlier in pregnancy than I'm used to doing these types of exams as well. So I don't know how much that was coloring my decision making here. It was not a let me find the SAG. It was not a previa at all. So it's all anterior. Here's the placenta anterior, and then here's that kind of irregular and vascular base. And then the cervix here was normal.
I agree though. I feel like I would have been concerned about those vessels, although I don't really know what.
I'll show you the pre and post contrast. I think this is, here's some post contrast imaging here. Kind of a venous phase, but all this is like engorged veins. And then a lot of the stuff on the on the anterior side. Some of this is just veins sort of effaced, I think. Anyway, the pathology on this was increta apparently, but they did encounter a lot of vasculature intraoperatively, but there was only like 400 cc's of blood loss, so that part was handled okay.
These placentas are very tricky.
Yeah.
Well, thank you.
Welcome.
Patient. I'm sorry, I didn't notice it. See, okay. So this patient, it has history of prostate cancer and came in for routine follow-up. And that is what he has. You can see there's bildial, kind of gallbladder is hydropic, and the pancreatic duct is markedly dilated to the level of the head where you can see there's some sort of lesion there. And just to compare, so he's on, I think, yearly surveillance. You can see a year ago, he looked pretty good. You know, maybe there was a trace kind of prominence of the duct which terminated at the neck. But I don't think this is something that you can actually call prospectively. The gallbladder wasn't dilated and there was no bilgel. So, you know, we saw this, we thought, okay, maybe, you know, with this appearance, obviously we're gonna start thinking about, what? Right, so do we think about cancer? This was the a PET was done within like a few weeks of CT, and you can see that the head didn't look that bad. So then patient had an MR, and on the MR again, you see markedly dilated duct. You can see it's, both pancreatic and biliary trees obstructed, like at the superior neck, superior head region. You can see there's a little bit of diffusion restriction right there. There's some lymph nodes. The pre shows you probably the best. This is the head with a normal signal, and then kind of this is hypo-enhancing, and then everything upstream to this region is markedly dilated duct. And there it is, kind of right there. So what would you recommend at this point?
EUS.
Right. So this was EUS, and path came back. Prostate cancer met.
Huh.
Wow.
I've never seen this before. But this is path proven prostate cancer metastasis to the pancreatic head, causing biliary ductal dilatation. I mean, both biliary and pancreatic ductal dilatation. Pretty wild, right?
Yeah, I've not seen that.
I've never seen this.
I have not seen it, but what was the PSA, just out of curiosity?
I have to look it up.
Oh, okay. Very weird for prostate to go to pancreas, but I guess any bad cancer can go anywhere.
But not only that, the fact that it caused right? It's like you think about pancreatic duct dilatation usually means it's ductal. So it's not just parenchymal met, it's like involvement of the pancreas.
But
So,
to me, it just means that it's a kind of fibrotic kind of tumor that can obstruct stuff. Right? Like if it's close enough to the duct, it will obstruct it, but only if it's a fibrotic kind of tumor, not like a lymphoma or something like that,
right. So I'm looking at the lab. So he, fascinatingly enough, his PSA, so his last PSA was a few months ago, and it was, no, I'm sorry. So his PSA was 0.05 at the time of the study. Ready? His CA99 was 1200. But the path is, yeah, I'll show you that. The path is not adenocarcinoma. The path is positive for malignant cell, adenocarcinoma, immunostat results based, wait, I'm just trying to find. And here, so the findings, cell block consistent with primary, like corresponding to the same as primary pancreatic, prostate. Not crazy?
Yes. Wow.
If there was a PSMA PET, whether or not that would be positive or not, that is often negative for
Right, so which is probably why the PET really was not hot,
right.
right? Yeah, here, positive for malignant cell adenocarcinoma consistent with prostate origin, yeah.
And adenocarcinoma, the pancreas is most often easy to see on the FDG.
Right.
Was their prostate cancer aggressive?
So
I'm just like so perplexed by these numbers too. Like the PSA was low. Like, how did this happen? Do you now start questioning the path? Okay, while you're looking that up, I'm going to share. Oh, Roopa, do you have one more?
the original path is read as positive adenocarcinoma consistent with prostate origin. I'm looking at the follow-up note that they put in. And the follow-up note is that they're not sure.
Ooh, the plot thickens.
It says-
Sometimes when it doesn't make sense, like it is good to go back and talk to the pathologist because sometimes they can, there can be overlap, or if it's poorly differentiated, it can
right,
using.
very odd.
Aarti, I have a quick one as a
Yeah.
companion to Victoria's case.
Okay, great.
So this was an older patient who came in with repeated history of pancreatitis. So the ER ordered a CT, and we did call changes of acute interstitial pancreatitis, but then noticed that the main pancreatic duct was severely dilated. On CT, it was hard to say if there was going to be any mass near the ampulla. Didn't see a
To
whole
me,
lot.
it's going all the way to the
It does.
patella, which to me
That's a
shows for
great
like a mucinous.
observation.
Yeah.
We were not too confident, but here it is on the MR. So it nicely looks like it goes all the way out to the ampulla. Didn't see any abnormal enhancement or soft tissue mass or anything. So we actually questioned if this is main duct IPMN, and this went to EUS biopsy, and that's what it turned out to be, was main IPMN. So
This is the
compared
type
to,
that like on endoscopy, they'll see the bulging
yeah,
with
papilla.
like mucin
Yeah.
coming out.
Yeah, so all of that was present. So just a contrast to Victoria's, where there was a mass, ill-defined mass in her case. In this, we struggled to see a mass. We also felt like it went all the way dilated to the ampulla, and they confirmed that at endoscopy. So just a nice correlation between endoscopy and imaging findings for main IPM.
Nice. Do you know if it had any malignancy or?
Low-grade mucinous.
Okay.
Yeah.
Not low-grade dysplasia, low-grade or.
Low-grade mucinous adenocarcinoma.
Okay, got it. Okay. Oh, okay. This is my case. So focus on the right abdomen. There's a
Gas and fluid filled mass, but whether or not it's bowel or not is the hard part.
exactly right. And it's involving the psoas, and it's going in like a couple of different directions. So it was really confusing, but there are some clues.
Some calcifications.
Yep.
Immunosuppressed patient.
Nope.
Some of this material in front of the psoas is definitely extraluminal, looks like that stuff.
Good. Excellent.
Like it's maybe like pseudomyxoma.
Okay. And then what about this thing here?
A big appendix with a mucosal.
Yeah. So, I mean, this like stumped us for a while, but because it was really hard to trace. But if you trace the colon, transverse colon across here, then it goes up, and then it kind of like connects to this thing. And if you just keep staring at this thing, the wall of it is a tubular thing,
Yeah.
right? And I'll show you on the coronal, it's a tubular thing that has like a wall, and part of it is calcified. And so if you just said that, like you weren't even looking at this, and you told somebody in the right side of the abdomen, there's a tubular thing with a calcified wall, you would think about an appendiceal mucosal. But because it was going in all these different directions, we were really confused. And basically it had perforated into, and had perforated. So, retroperitoneal mucinous, basically pseudomyxoma, but also involving the psoas muscle. And I'm going to show you the coronal just to kind of convince you more that this was a giant appendiceal mucosal.
Oh, wow.
Yeah. So there is this entity called a giant mucosal. If you look in the literature, there's even like bigger ones and stuff. But ours was basically originating up here. Okay, well, anyway, it originates here, and then it goes here, and then it comes down into this thing. And then like a little offshoot of it so it's not like calcified at its tip, it's like a little offshoot that's calcified. But that was one of the clues. And actually the surgeon ended up calling it. He was like, I think this is a huge appendiceal mucinous neoplasm. And they resected it, and they en bloc had to resect all of this other stuff and the psoas. Unfortunately, there has been some recurrence, which is not uncommon with pseudomyxoma. But yeah, this was an appendiceal mucosal, and it had mostly high-grade mucinous neoplasm with foci of adenocarcinoma. So it wasn't a lamin, not a low-grade appendiceal mucinous neoplasm, but a high-grade one. Giant.
Do we have time for one more quick one?
Yeah.
Kind of a show and tell, but it's just a nice
Let me
case.
stop sharing. So just try to take over my screen.
Kind of a combined chest and abdomen case. Large mediastinal soft tissue mass, and then as we scroll down, the kidneys are
Oh boy.
very classic. Yeah.
Lymphoma, terrible lymphoma.
Yes. So
Wow. With
very
renal.
nice. Yeah, bilateral intrarenal masses. So
So
we're
wait, tell me
seeing
the 4 T's again. So like if we just saw the chest, it'd be the 4 T's, which is like teratoma, thyroid
thymic mass, teratoma,
lymphoma,
terrible lymphoma, thyroid.
that.
Thyroid. And then for the kidneys, lymphoma can be either solitary mass, multiple masses, perinephric only, or diffuse infiltrative in the retroperitoneum, and periureteral soft tissue thickening. So this is just bilateral hypodense masses.
By the way, does this person have like omental disease?
They do, I think. Like
Yeah,
the
the omentum is like
nodes and
obliterated.
very nodular looking.
Wow.
Yeah.
But you know, this looks so bad, but this is actually the kind of thing that could be maybe shrink away with chemotherapy.
Yeah, you'd
Yeah.
prefer a lot of other things.
Yeah.
Yeah.
Okay, that's it.
It's a good one. That reminds me of one of my early fellow cases that I was a fail on, I think, was a large retrosternal goiter, like thyroid, and I just got it wrong. How you learn.
Yeah, those sometimes look heterogeneous, calcified, extending from the throat. But yeah, I also one time I was like, oh, this is a classic lymphoma, and it turned out to be sarcoid, which is even better than having lymphoma. But cool. Okay, see you guys later. Bye.
Okay, thank you, everyone.
Bye.